καλωσορίσω στην απόψηλή μας συγκέντρωση, η οποία στόχον έχει τη διαφώτιση. Έχουμε την τιμή να έχουμε μαζί μας απόψε έναν διακεκριμένο καθηγητή, τον Πάρη Τεκκή, ο οποίος θα μας μιλήσει για τον καρκίνο του εντέρου, που είναι η ειδικότητά του. Ο καθηγητής Πάρης Τεκκής είναι καθηγητής και σύμβουλος χειρουργός του Παχαίου Εντέρου του Τμήματος Χειρουργικής και Καρκίνου στο Imperial College London του Ηνωμένου Βασιλείου. Ως επίσης σύμβουλος χειρουργός του Παχαίου στο Royal Marsden Hospital, Chelsea και Westminster Hospital. Απεφοίτησε από την Ιατρική Σχολή του Πανεπιστημίου του Νότιχαμ το 1994. Η μεταπτυχιακή χειρουργική κατάρτισή του ήταν στο νοσοκομείο του St. Mark's, το νοσοκομείο St. Mary's στο Λονδίνο και στο Cleveland Clinic, Ohio, στις Ηνωμένες Πολιτείες. Παράλληλα, με τη χειρουργική καριέρα του έχει απενεμηθεί έναν υψηλότερο πτυχίο MD από το Πανεπιστήμιο του Λονδίνου το 2003 για την έρευνά του στατιστική στην ιατρική. Είχε πρωτοδιοριστεί ως ανώτερος κλινικός λέκτορας και σύμβουλος χειρουργός του Παχαίου στο νοσοκομείο St. Mary και Imperial College το 2004. Προήλθε χειρουργό στο The Royal Marsden το 2008 και στη συνέχεια καθηγητής το 2011. Ειδικεύεται στην ελάχιστη επεμβατική χειρουργική του Παχαίου Εντέρου. Ο καθηγητής Τεκκής και η ομάδα του είναι σεβαστοί διεθνώς για το έργο τους σε προχωρημένο καρκίνο του ορθού και τη χειρουργική επέμβαση για τη φλεγμονώδη νόσο του εντέρου. Είναι ο πρόεδρος της Beyond TME Collaborative, υπεύθυνος για την δημοσίευση των διεθνών κατευθυντηρίων γραμμών και διαχείριση του προχωρημένου καρκίνου του εντέρου στο Ηνωμένο Βασίλειο. Έχει επιβλέψει πάνω από 30 MD διδακτορικά. Έχει δημοσιεύσει πάνω από 250 άρθρα σε ιατρικά περιοδικά με πάνω από 7.000 αναφορές. Έχει συμβάλει σε 22 βιβλία και έχει δώσει πάνω από 350 παρουσιάσεις και διαλέξεις σε 22 χώρες. Ο καθηγητής Τεκκής έχει λάβει πάρα πολλά βραβεία και τιμητικές διακρίσεις, μεταξύ των οποίων συμπεριλαμβάνεται the Hunterian Professorship από το Βασιλικό Κολέγιο Χειρουργών της Αγγλίας. Είναι επίτιμος καθηγητής του Πανεπιστημίου Αγίου Γεωργίου στη Λευκοσία και του Πανεπιστημίου Αθηνών. Είναι επισκέπτης καθηγητής στο Πανεπιστήμιο του St. Mary του Hong Kong και στην κλινική Cleveland στο Ohio των Ηνωμένων Πολιτειών. Άλλα βραβεία περιλαμβάνουν το David Dunn, μετάλλιον από την Ένωση Ενδοσκοπικής Χειρουργών της Μεγάλης Βρετανίας και της Ιρλανδίας και την Κοινωνία του Piedmont Χειρουργών Παχαίου Εντέρου και Ορθού της Αμερικής. Ο καθηγητής Τεκκής είναι ο εκπρόσωπος του Ηνωμένου Βασιλείου για την Ευρωπαϊκή Κοινωνία της Κολοπροκτολογίας και μέλος του Συμβουλίου του British Association of Surgical Oncology. Είναι μέλος της εταιρείας του Πιελικού Χειρουργών της Αμερικάνικης Εταιρείας Παχαίου Εντέρου και του Ορθού, μέλος των Σύλλογων Κολοπροκτολογίας της Μεγάλης Βρετανίας και Ιρλανδίας, μέλος του Σύλλογου Χειρουργών της Μεγάλης Βρετανίας, Ιρλανδίας, καθώς επίσης και στην Κύπρο. Θα καλέσω τώρα τον καθηγητή Πάρη Τεκκή να αρχίσουμε τη διάλεξη μας.
Thank you for the kind invitation. I'm going to say everything in English because obviously I won't be able to say the medical aspects in Greek, having done all my training and studying in this country. So what we are going to be discussing today is prevention and management of bowel cancer. For people who know or the hospitals, this is the Royal Marsden Hospital, which is the hospital which I work. It is the cancer hospital of the UK, and it's a reference point where all the patients who have advanced disease or complex cancer are referred to us. This is the London Clinic, which also I'm one of the professors there, and we also deal with the cancer management at this place, which is both are in central London. So what I'm going to be discussing today is bowel cancer. For the bowel is this part of the bowel, which corresponds to the gastrointestinal tract. If you can imagine the liver being the blue bit up at the top left-hand corner, you have the small bowel, and then it leads onto the large bowel. And a number of people will in fact develop bowel cancer in our lifetime. And I'm going to be explaining later on who gets it and who are at risk of getting it. We get approximately 32,000 new cases in the UK per year, and it's the commonest cancer that affects the gastrointestinal system. It's the second commonest cause of death in the UK, and we have 16,000 deaths, I'm afraid, every year. Now, there are two groups of patients who develop cancer. They are the people who are asymptomatic, which means these are patients who have no symptoms whatsoever. They are a small proportion of patients, and the only way of being able to identify these patients is by doing what we call screening. Then there is a group of patients who have, actually these are not patients, these are people. Now, people who have symptoms then are classed as patients. And the symptoms that we worry about are basically shown on the left, which are change in bowel habit. What it means by that is a change from a normal bowel frequency of, for example, from once a day, you start going 3 or 4 times a day. But this change of bowel habit needs to be persistent. So it's not a question of having 1 or 2 goes and then you say, okay, I've got a change of bowel habit. It has to stay and be there for more than a month, because if you travel abroad, you will have a change of bowel habit. Then bleeding is an important subject and symptom, but only 1 out of 10 patients who have bleeding do have cancer, because the majority of patients who have bleeding is usually related to hemorrhoids or some other problem in the bowel. I've put no perianal irritation because patients who have cancer usually have no anal symptoms, whereas patients who have hemorrhoids and fissures and other difficulties with the anus, usually they have irritation and itching. Now, pain is a symptom, but it has to be put in conjunction with other of the other symptoms. Weight loss is important, and this is persistent weight loss over a period of time. And obviously lethargy and a lump. Lump, usually most patients are not able to feel, but we tend to pick them up. And what I've put here, I've put persistent symptoms, because the key here is not just having one, but a combination of those and be there and not go away. Now, how do we manage this? And this is what I'm going to be discussing later on. We'll be looking on how we diagnose it. How do we stage? Stage means how do I identify how advanced the tumor is? And it can spread either locally within the tummy, or it can spread elsewhere. And there is a proportion of patients who would require radiotherapy, which is X-ray treatment. Proportion of patients might require chemotherapy, and some would require surgery. Now, surgery is actually the mainstay of treatment, because that's the only avenue we have to give cure. The radiotherapy also cures a proportion of patients, around 10%, and then the chemotherapy is predominantly used as an adjunct to prolong the survival of patients. Now, a lot of patients and people will ask, what are the chances of developing bowel cancer? And from this slide, you'd be able to see that there are different groups of patients. There is a small minority of people who have what we call FAP, familial adenomatous polyposis. We have a number of families, in fact, in Cyprus and in Greece, as well as in the UK, who have the genetic predisposition of developing cancer, and every single member of that family will develop cancer because it's a dominant trait, and it's less than 1% of patients. And those, all of them, 100% will develop it. Then we have the hereditary non-polyposis cancer, which is, again, less than 3% of the population. They have a genetic predisposition, and the majority, 70 to 80%, will get cancer of the bowel. Now, what are, in fact, we do have in Cyprus is inflammatory bowel disease, which is Crohn's and ulcerative colitis. And I'm sure some of you in the room probably will have one, will belong to this category. And that's the lifetime risk of somebody who has had ulcerative colitis of going on to develop cancer. And then we have the family history of a cancer in the family, and that's probably 10% of all patients. So if we put everybody together, we have 15% of everybody who present with a growth in the bowel will have some form of genetic or family history, and the rest are sporadic. Sporadic means they come out of the blue and doesn't pass on within the family. So let's look at what is the baseline risk. Baseline risk is if somebody has no family history, they have no predisposing factors. If you think of what your age is now, within the next 10 years, that's the risk of developing cancer. For example, if we look at a 70-year-old, the risk of getting cancer is 1 in 30. If you are 80, then it's 1 in 25, so 1 in 4 by the time we get to 80. So it's a problem of age. The older we become, the higher the chances of developing cancer. So the way to identify it is to be able to find a cutoff, some specific age, where you'll say, I'm going to do something to identify whether I have a predisposition to getting cancer. And the cutoff here is between 50 and 60 years, because it's 1 in 100 or 1 to 50. Now, let's start thinking now about family history. Now, if you have a 1 first-degree relative over the age of 55, what I've shown in yellow is the risk of developing the disease. And you can see that it doubles the risk for that age group. So it's usually the elderly people. So for a 70-year-old, which the majority start at 69, that's the average age, 70, you've got a 1 in 15 chances of developing cancer. And by the time you are 80, it's 1 in 12. And that's if you are mother, father, or brother or sister, anyone had a cancer before. Now, if any one member had a tumor below the age of 55, then the risk triples, and it takes across all ages. So you can see the recalculation now for age by age. So by the time you are 70, the baseline risk goes to 1 in 10. By the time you are 80, it's 1 in 7. And this is a young relative with cancer, essentially, beyond the age.
Are you saying any type of cancer?
No, bowel.
Just
Has to be bowel. Then this is now when we have 2 first-degree relatives, or you have 1 first-degree relative and 1 second-degree relative on the same side of the family. Second degree, same side of the family. The risk is 6-fold. And you can see what's it like now. So these family members would actually be screened and checked at a much younger age to be able to pick up the disease before it develops into cancer. So the cancer usually develops from a polyp. And if we pick up the polyp, a polyp will take up to 5 years before it turns nasty. So this is what I'm going to be discussing now. So as I've shown earlier on, we have the baseline risk. We have an intermediate risk, and we have a high risk. Now the high risk are the people who is the familial adenomatous polyposis, and we've got the genetic, basically determined patients to develop tumor. And those, by the age of 25, they will get a colonoscopy, which will come to the colonoscopy what it is. And then the young ones will go from age 15. Then we've got the intermediate group, which is what I was referring earlier on, which are the family members, 1 degree or second degree relative. And those, we would advise a colonoscopy from age 50. And that gives you protection for approximately 10 years if you've had a normal colonoscopy, and then you need another one after 10 years. And then we've got the baseline risk. The baseline risk, we get it checked in the UK with a fecal occult blood test, which I'll show you later on at age 60. In Australia, it's at age 55. In the US, they go straight to colonoscopy, but in the UK, we don't have enough endoscopies to be able to do it as a screening on colonoscopy. So although it has come into the UK, the screening with colonoscopy, most of them will have flexible sigmoidoscopy. And the first step is the fecal occult blood. Now, the colonoscopy is the gold standard. What I mean by gold standard, it is the optimum strategy for picking up the polyps. It has the highest sensitivity on being able to pick it up. It does have a complication of 1 in 3,000, and in 5% of patients, the endoscopist is not able to complete the examination. So although, and as I said, we don't have enough of them. Now, this is what is used in the UK. We use the fecal occult blood test. You can buy it from the chemist, although it will come to most of us when we've reached age 60 with a booklet. You send 2 of these and you send them home, back to the screening center. A proportion of patients will have an abnormal test, which are then recalled for a second test, or they come up for a colonoscopy. And that's how we pick them up. This way, we pick up approximately 15% to 18% of all cancers with screening. The remaining ones are not picked up. So does the screening work? What I've put here is that for every 10,000 patients age above 50 who are offered this test, and then this test is repeated every 2 years, the fecal occult blood, 2/3 have at least one test over 10 years, we save 9 bowel cancer deaths are prevented by this screening program. And this is basically, you can imagine how expensive it is having to test 10,000 patients to save 9 lives. But it is important because we do save 9 people. So what other tests do we have instead of the fecal occult blood test? This is the colonoscopy. And then on the colonoscopy, you can see a polyp on this side. And more recently, we have what we call a virtual colonoscopy, which is what you are seeing on the right side. Now, what a virtual colonoscopy is basically a CT scan, which then transforms the bowel into a 3-dimensional structure, and then you are able to walk through it and be able to identify potential polyps. So this is the latest technology that we have in the UK to be able to see as a substitute to the colonoscopy, although it is not as accurate as the normal colonoscopy. It's approximately 90% the accuracy of this. So this is a virtual colonoscopy using a CAT scan. So this is one of the studies that we published earlier on, looking at how sensitive it is on picking up cancer, and it was around 96%. And it was able to exclude cancer in most of the patients. The problem we have is it cannot pick up any polyps for less than half a centimeter. And there's a lot of false positives. False positives means it thinks that you have cancer because of a small piece of stool that remains within the bowel. And then we have a lot of anxiety that patients have to come back and have a proper colonoscopy having had this. So we tend to use this one predominantly for the more elderly patients or the ones who are a bit more anxious about having the colonoscopy and they are worried about the complications. Now, another modality is using MR, the MRI. And with an MRI, we are able to do the same thing and examine the large bowel. This is more an evolving imaging modality to be able to do a virtual colonoscopy with an MR. It's more expensive, it takes longer, but it has no radiation. And it is actually something that we are seeing coming more and more in the next 5 to 10 years. So MR, the sensitivity is a bit less. We are being able to pick up cancer in 90% of the patients. And specificity, which is the ability to exclude cancer, is around 98%. Again, the similar problem, we are not able to pick up polyps with this because there isn't any, we haven't got a way of tagging the stool to know whether this is a stool which has remained within the bowel or is a polyp that has remained within the bowel. So the next thing, if we've established the diagnosis and we found the polyp, we take it out. And if we take out these polyps, not all polyps will turn cancerous, but if we take them out and we continue to do the colonoscopies, then we prevent bowel cancer. And that's the best way of prevention. Just get yourself screened, and then you know that you are unlikely to get an interval cancer. Interval means in between the two colonoscopies, you develop one. Now, how does it spread if you are unfortunate to have a tumor? It spreads directly from one organ to the next. It can spread through the lymph glands, which supply the bowel, and then through the bloodstream. And it has 4 stages. Stage 1 is if it's confined to the bowel wall and it hasn't gone anywhere, which is the A. B is when it's gone through the bowel wall, and you can see the life expectancy for each of the patients. So it's around, if you have a stage 1, you have a 90% cure rate once the cancer is removed. If you have a stage 2, it's around 75%. So 3 out of 4 patients will live and beyond 5 years, and the cancer will not come back if you have stage 2 disease. If you have stage 3 disease, which is on the right, it means it's gone through the bowel, but also is spread to the lymph glands outside. And that's got a 50% 5-year survival. And finally, you have the metastatic cancer, which has spread either to the lungs or to the liver. And then they are classified into 2 groups. The ones which the cancer can be removed either by removing part of the lung or part of the liver and the primary cancer. And these patients have a 30% survival, which means 1 out of 3 will live and independently and not have a cancer ever coming back. And unfortunately, the people who cannot be operated, as I mentioned earlier on, chemotherapy can buy a lot of time, but unfortunately, most patients will not survive beyond 5 years. So how do we assess if there is any local spread of where the tumor is? And that's done with an MRI. Now, if you can imagine, this is the rectum, which is the tail end of the body, and the anus, you can see that at the bottom of the screen. And then the MRI takes images coming across. It makes a lot of noise, but that's the best way of identifying where exactly this is. And you can see here, we look at the rectum itself, and this is the area of what is removed, and then we can see how far is extending to the level of where we can remove this tumor. Obviously, you take it out, and then you can join the bowel together. And these are the MRI pictures of a tumor, and you can see this is a male patient, and the bladder is at the front, and here is where we are looking to remove the tumor, and you can see how it's spreading. It's a black bit. Sorry, this is not working very well. That's the black bit that is coming through, and that's where we remove it and then join it together. Now, looking at how accurate is the MRI in staging and being able to identify how far it's spread is actually very good. We are able to stage them appropriately and get it right in 85% of the patients. What it means is in 15% of the patients, the MRI is not as accurate, and then it's our judgment when we do the surgery to be able to change our technique, to be able to get everything out and not leave anything behind. Now, how do I identify whether there are any metastases, whether the tumor's gone to the lungs or the liver? And that's done with a CT scan. And most patients ask, why do I have an MRI? Why do I have a CT scan? The CT scan is used to look at the lungs and the liver. The MRI is like taking a high-resolution image of the pelvis itself just to look at the tumor. And the MRI takes 3 minutes to do the whole body. whereas the CT scan takes 3 minutes, whereas the MRI will take half an hour to do this much. So it's impossible to MRI the whole body because it would mean having to stay in there all day. Now, this is a CT scan. You can see there's a small cancer in the liver there. And this is what we do. And then this is a latest thing, which is called a PET scan. And it allows us to identify metastatic disease, and is the most sensitive way of picking up distant disease with a PET scan. It's quite expensive, and we only use it for specialist cases. We don't use it routinely for non-advanced disease because obviously of the cost as well as the availability across the country, because we have enough PET scanners, but for example in Cyprus we don't have a PET scanner. And it tells you where the tumor is because it measures activity and function of the tumor, because you give a radioactive glucose into the body and it's picked up by the cancer itself. And then it is 10% more accurate in picking up metastatic disease than any other modality. So who should be treating bowel cancer? If you go to a surgeon or to anybody who says, tomorrow I need to take it out, without going through a tumor board, what we call a multidisciplinary team, in the UK it's called MDT, multidisciplinary team, in the US it's called tumor board, then we are probably being undertreated. Because you need to have a team of doctors coming together to be able to discuss on a patient-to-patient basis what should be happening and what is the optimum strategy for combating the cancer. And the MDT team are all these people. All together, we meet up every Monday and then we discuss every single patient at the Royal Marsden Hospital to find out who needs radiotherapy, who needs chemotherapy, who needs surgery, and in which order, and how much of it. So as I said, there are different modalities. I've already mentioned that. And then we need to use a combination of this depending as to what is necessary. So it is individualized treatment. Every patient requires something different. They are not all the same. And this is why we need the team. Now, when do we use X-rays? X-rays is basically we identify which are the good cancers, the bad ones, and the ugly ones, like the movie. The ugly one, we give them X-ray, because with the X-ray, we can make it smaller. And in fact, on 10 to 15% of all tumors, who we give them X-ray treatment, the cancer disappears completely. On some of the anal cancers, in fact, 80% of patients, the cancer will disappear. And that helps us to identify these patients and follow them up, because we are currently running a trial at the Marsden Hospital on deferring surgery if the cancer has gone completely, and then offer the surgery at an interval of when it appears back. Because on the majority of patients, once it's completely gone, possibly we might not need to operate. We don't know at present who we should be operating on if it's completely gone, and that's why we're running the trial. Now, the ones which are halfway there of being bad, we give them radiotherapy which only lasts 1 week instead of 5 weeks. And it works in the same fashion on making the tumor slightly smaller, but not so much as the big one. But more importantly, it stops it from coming back. So it reduces the likelihood, if you've taken the cancer out, on the cancer reappearing at the same spot 2, 3, 5 years down the line. Now, if it's a good one, which means it's small, it hasn't got any lymph nodes, it hasn't spread anywhere, then we go straight to surgery, because these are the good prognosis tumors. Now, a lot of patients come and ask me, can it be done keyhole? Or should I have a cut? Now, it's the patient's choice and it's the surgeon's choice, because some cancers are better taken out open, some are better taken out keyhole. Now, most patients, they want it keyhole, but it's not always that is the right thing to do. And for example, this one is a young lady who had 3 tumors. I don't know whether you want to see this, but this is the keyhole approach of whereby the patient, we avoid having a big cut, and then we are able to move the intestine from the inside, do the dissection, all of it with using instruments from the outside, and then being able to take it out through a small hole, join the bowel, and then drop it back inside, which essentially, it leaves us with a small cut, 4 or 5 centimeters instead of a big cut. So the patients are able to get home much more quickly. The incidence of wound infection is smaller, the recovery is quicker, and the postoperative pain is less. Some cancers are not good to be taken out keyhole. And I would say for most men who are obese, it is not the right thing to do. Simply because obesity is one of the things that stops us from doing a good cancer operation keyhole. And having done 500 cancers keyhole, I can tell that if somebody is 100+ kilos, I would probably be going for an open procedure, because open procedure you have more control. And some positions of the tumor, again, are not good to be done keyhole. So it's a combination of what the patient wants and what we advise. So if we move on, this is the type of incision that you would have, tiny like this, instead of a big cut in the midline. Now, I've already mentioned the advantages. And again, we have to be sensible as to what is the best technique for the best outcome and for which patient. If we are not careful, you end up with this situation, whereby you advise somebody to have it done because it's the in thing to do, and the neighbor told me that this is the best thing, and they all come and they say, I want it, I want it. Okay, you want it, there we are. You get stuck sometimes. And with cancer, you don't want to be in that situation, because if you get stuck, it will come back. You want to have the best procedure and you do it well first time around. Although there is a second chance, and that's what I specialize on, fixing the problems that have arisen in other places and then give a second chance, that the results are not as good as first time around. So one last slide which I want to discuss, because some patients will have metastatic disease. And some of them are inoperable, and they will come to us and they say, how long have I got to go? And is there a possibility that chemotherapy can prolong my life? If you look at going back to the 1960s, when we only had one drug, the life expectancy, if you do nothing, and you've got inoperable metastatic disease, approximately 6 months. But if you add on one drug, if you look at back in the 40, 50 years, we could extend it up to 9 months. Then we had 2 drugs. We've extended it up to 12 months. Then we can have 3 drugs. And then we've gone up to beyond 12 months. And now we've got the combination of treatments, and we change from one to the other. And you can see we're extending up to 18 months. And now we've got the new medicines which are coming up, which is the immunotherapy and chemotherapy. So we're extending and extending. And I've put actually a question mark here, because we can actually have people, and at the Marsden they have the phase 1 trials, which are all the new drugs that are coming up. So a patient with metastatic disease is not that we're going to die tomorrow, but you can see we're going up to 3 years, 4 years and beyond with all the new technologies coming up, and then being able to enter a chemotherapy regime, stop it, start it, change it, and then we prolong life as much as we can. So that is for the patients who have got advanced metastatic disease. So it's not all over, because we can give a decent quality of life as well as prolonged survival. So what in conclusion, I would say that for people who are asymptomatic, screening is important, and we should be thinking about it. You need to, if you go to a surgeon, be sure that you've gone through a multidisciplinary team, so we discuss your case and it's not just somebody saying, yes, I'll do this. surgery is the prime modality because that's what's offered cure, but in combination with other treatment, and I've said laparoscopy is a good thing, and we'll use it appropriately. And I said earlier on, chemotherapy improves survival. Thank you very much.
Εκ μέρους του συνδέσμου θα ήθελα να ευχαριστήσω τον καθηγητή Τεκκή για την τόσο διαφωτιστική ομιλία που είχαμε και όπως όλοι ξέρουμε η πρόληψη είναι το καλύτερο πράγμα, οπότε πρέπει αυτά που έχουμε ακούσει απόψε να τα βάλουμε στην καθημερινή ζωή μας και να προσέχουμε να κάνουμε τις εξετάσεις μας όπως πρέπει. Θα ήθελα να σας χαρίσω ένα μικρό δώρο εκ μέρους του συνδέσμου. Σας ευχαριστούμε πάρα πολύ. Όπως όλοι ξέρουμε και ακούσαμε, ο καθηγητής είναι πολύ απασχολημένος και όταν το ρώτησα εγώ πριν 4 μήνες, Πάρη, μπορείς να μας κάνεις μία διάλεξη, η απάντηση ήταν αμέσως, ναι, πότε θέλετε. Και βάλαμε την ημερομηνία για απόψε. Πάρη, σε ευχαριστούμε πάρα πολύ. Το εκτιμούμε ιδιαίτερο σε αυτό. Επίσης, θα ήθελα να ευχαριστήσω τους φίλους Άκην και Μαρία και τον Λορέντζο του Μάζου, οι οποίοι μας φιλοξενούν εδώ απόψε δωρεάν. Τα ποτά επίσης είναι από αυτούς, τα εδέσματα είναι από το σύνδεσμο. Μαρία, σε παρακαλώ, λέξεις της οικογενειακής